Excellent. Okay, so I'm really excited to spend a few minutes talking about antipsychotic pharmacogenomics. It's a topic that we haven't formally covered yet in the context of our ECHO presentations. Given the case, we're also going to talk a little bit about implications for long-acting injectable formulations, which adds an element of complexity and an area for further evaluation within this topic. So, just as a bit of backdrop, want to highlight that as people here are likely aware, antipsychotic medications have originally been indicated and studied for the treatment of schizophrenia, but their use has evolved to include a growing list of other indications. In fact, the last assessment of utilization that I reviewed that was within the last couple of years suggested that depression and bipolar disorders actually were more common for utilization of antipsychotic medications as compared to schizophrenia, likely due to the greater prevalence of those mood-related conditions. But suffice to say, there are a number of other therapeutic areas where the use and benefit of antipsychotics is also growing. As it relates to utilization, quetiapine, aripiprazole, olanzapine, and risperidone are all on the top 200 prescribed drug list, at least as it was updated last in 2022. So we'll be getting 2023 data from that sometime in the near future. As a class, in 2022, these agents, antipsychotics as a whole, represented almost 30 million prescriptions, and those were represented about 10% of all Medicaid prescriptions. So very commonly used. Unfortunately, there's a range of 30 to 75% of individuals who discontinue therapy within a year of starting the medication, depending on population that you look at and the study design that's used. The reasons for discontinuation tend to be a combination of either tolerability issues or lack of effectiveness, or some combination of the two, as they're often hard to disentangle. Jumping straight to the chase here, I wanted to lead off with an overview of pharmacogenomics for antipsychotics as it relates to what's currently in FDA drug labeling, as well as guidelines. And I say this with a caveat that, as Pam alluded to, the CPIC group is in the process of developing an antipsychotic guideline at this moment. So I'm involved with the leadership team for that, and we're currently in evidence review and happen to be looking at the agent in question today. So it's a timely convergence of those activities. But as it relates to what's currently available involving discrete recommendations, we have 4 first-generation antipsychotic medications and 6 second-generation antipsychotics that have actionable drug-gene interactions. And so a couple of things to take away from this slide here. First of all, as it relates to gene, for all but one of these medications, the gene of reference is CYP2D6. The one exception is quetiapine, and in the Dutch Pharmacogenetics Working Group guideline that was recently published, they had a recommendation for either choosing an alternative or using 30% of the usual dose in CYP3A4 poor metabolizers, or those who are STAR22 homozygotes. For the rest of these, largely as it relates to the FDA, the most common quantification of dose adjustment is a 50% reduction of usual dose in poor metabolizers, with a little more fine-tuned recommendations that often come from the Dutch group. Now, as it relates to long-acting injectables, only one of these has actionable information that's included in the product labels, and that's related to aripiprazole. So they have recommendations for both the oral formulation as well as the long-acting injectable formulation. And we'll talk a little bit more about that in some subsequent slides. But they do have dose adjustments as well as avoiding some loading dose formulations that are unique to one form of aripiprazole LAI. Now, as it relates to LAIs, they have a number of advantages and a few disadvantages that impact their utilization. For patients who are open to receiving an injection, they can be very convenient. From a provider standpoint, they allow us to have very clear and transparent assessments of adherence. And we know that adherence is often a challenge for a variety of reasons. And so when we know when exactly the last administration was, we can track that very closely. So because of that, and because of the consistent delivery and bioavailability that can occur over the course of anywhere from 2 weeks to now we have some formulations that can go out to 6 months for certain LAIs, they can lessen the probability of relapse or rebound symptoms, particularly when those are anchored to adherence challenges or intermittent use. On the flip side, sometimes there are cost and insurance coverage challenges. Titration and dose changes can present a challenge because the impacts of a change may not be seen for quite some time due to the very long half-life and extended PK parameters for these LAIs. So what we do now may not be fully realized for a period of months, and that can present a challenge when we need to maneuver doses. We put together some background on available long-acting injectables just as a framework for what's available and maybe how they might relate to pharmacogenomics as we may apply this to the case. As far as first-generation agents, the two most common that are considered here in the United States are flufenazine decanoate and haloperidol decanoate. As it relates to metabolism, both have an element of CYP2D6 involved with them, although the genotype implications for specifically for LAIs are not well described at all. And if you notice that if you take a look at the cost here and visually compare that to the second generation agents that are now commonly used, and this is a very busy slide, and I'll just kind of highlight a few things that I want you to take away from it. Is that for the newer agents, we do have a growing number of formulations and agents that have LAI available. We have aripiprazole, olanzapine, paliperidone, and risperidone. For these, as it relates to pharmacogenomics, CYP2D6 has a significant metabolism aspect for aripiprazole and risperidone. Olanzapine is not, the long-acting form of that is not very commonly used at all because of some intensive monitoring that's required for that. Paliperidone, if you recall from, for those of you who may have been on one of our last ECHO presentations, came up in the context of an antipsychotic discussion as the only agent within class that doesn't have significant hepatic metabolism. So it may be an alternative when there's a consideration for some drug-drug interactions. So a lot of different formulations, a lot of different frequencies and administration-related options. And so options are good. Sometimes dialing in also on which one we want to use may present itself with its own challenges. So what I wanted to do here is spend a little bit of time talking specifically about two LAIs with PGx relevance, aripiprazole and risperidone, just to let you know what the data kind of looks like as it currently stands. And starting with aripiprazole, this is an agent that's metabolized by CYP2D6 and CYP3A4. It's metabolized to an active metabolites. The most predominant one is dehydroaripiprazole, which is thought to have similar pharmacologic properties to aripiprazole. So when we're looking at PK and exposure data with a parent and an active metabolite, as it relates to this combination here, probably the most clinically relevant is the sum total of aripiprazole and dehydroaripiprazole, and we call that the active moiety. The data in publications are often parsed out with active moiety, parent, metabolite, and then parent to metabolite ratio. As I alluded to in that intro slide, there's some FDA labeling anchored to altered 2D6 metabolizers. And there's two different formulations of aripiprazole long-acting injection that I'll cover here. This is Abilify Maintena. Within the label there, for known 2D6 poor metabolizers, they recommend a dose of 300 milligrams every month. And just for reference, the usual monthly dose is at standard doses for schizophrenia is 400 milligrams per month. And then for individuals who are poor metabolizers also taking a CYP3A4 inhibitor, that dose is further recommended to be adjusted down to 200 milligrams per month. Aripiprazole Loroxol is another formulation that has some different pharmacokinetic characteristics. It's got a pharmaceutics fatty acid chain that's attached to it that helps with extend the PK parameters of it. The FDA label for Aristada itself is rather ambiguous in its coverage of 2D6 metabolism-related info as it relates to genetics. I've become aware that that may have been an unintended omission, so there may be some changes in that, because they do have fairly detailed dose adjustments in the context of being a poor metabolizer and taking an inhibitor that can take a little while to digest. Now, there's a separate label for something called Aristada Initio, and this is essentially a loading dose formulation. It's got some different, the crystal structure of it is smaller, which creates a more rapid peak for PK-related purposes to get people to steady state sooner. Now, within that label, there's explicit language to avoid this in those who are known to be 2D6 poor metabolizers or taking strong inhibitors of 2D6 and 3A4. So something that's a little different, and you wouldn't know it unless you knew that there's a separate label for this Initio related formulation. So what do the data look like? As it relates to aripiprazole, there's two examples that I'll show here. The first is a nice study that was done in 2020, which compared aripiprazole long-acting injection versus oral concentration characteristics across CYP2D6 genotype groups. This was 635 individuals. 166 of them were using LAI, which is the Maintena formulation, or oral. I think the take-home message here is that compared with normal metabolizers, both PMs and NMs IMs had significantly increased exposure, and it was about 1.7-fold higher and 1.5-fold higher in poor metabolizers and intermediate metabolizers, respectively. And these differences, these effect sizes look nearly identical for both the LAI and oral formulation, which I found very surprising. So over here on the left is the LAI, and this is a dose-adjusted concentration across ultra-rapid, normal, intermediate, and poor metabolizers. You can see that the IMs and PMs are pretty close, but maybe a little more of a stair-step type of feature as compared to the oral formulation, where IMs and PMs look pretty much identical. But that could be a function of just a smaller number of data points for the LAI. So when you plot these box and whisker plots of concentration across activity score, the LAI and the oral look nearly identical. A second example was published this year with a smaller number of patients. This was 74 receiving aripiprazole. Again, I think it was the Maintena formulation based on what they were describing. And these three data plots show the active moiety, aripiprazole in panel B, and then the parent to metabolite ratio in panel C. Focusing just on the active moiety for the sake of time, in the right side of this, which is the dose-adjusted concentration. What we see here, again, is that poor metabolizer concentrations are significantly higher than normal metabolizers, although here the effect size for intermediate metabolizers seem to be different than poor metabolizers. So maybe in the same direction, although the magnitude of effect for intermediate metabolizers remains to be clarified a little bit more. Briefly wanted to talk about risperidone and paliperidone because those are the two other most commonly used long-acting formulations for second-generation antipsychotics. Risperidone is predominantly metabolized to 9-hydroxyrisperidone by CYP2D6 and to a lesser extent 3A4. So this is similar to aripiprazole in that it's an active metabolite, very similar pharmacodynamic properties. The active moiety is considered the sum total of risperidone and 9-hydroxyrisperidone. And so the data are often presented in a very similar fashion as compared to aripiprazole. FDA label does note that there's reduced metabolism apparent to metabolite, although in their assessment, the data that they had submitted, they didn't have specific PGx dose recommendations because the sum total of that active moiety did not differ in poor metabolizers compared to normal metabolizers. Although they do have reductions for inhibitors, so there's a little bit of insight that we can gain from that. I've got two examples that I'll cover briefly for the risperidone LAI as it relates to 2D6. The first is a study of 90 patients from a therapeutic drug monitoring database in Europe, and this is the same database that's used for a number of other population pharmacogenomic studies. Just briefly down here in red, I have highlighted the active moiety dose-adjusted concentrations. And while they parse out their kind of genotype groupings a little bit differently than CPIC does, I think what you can generally infer is like an ultra-rapid metabolizer group, normal or extensive metabolizer, intermediate, and then either poor or severely reduced over here in the far right. And all of these look the same with the exception of the poor metabolizer group, which has significantly increased concentration and exposure as compared to those others. So again, a signal in that direction that could be clinically relevant. A second and smaller study had 42 patients had similar types of effects, although they only had one poor metabolizer in their group. So you can see the stair-step feature just looking at the active moiety, although the differences weren't statistically significant due to the smaller numbers, but again, maybe some similarities in the direction of effect, although the magnitude of that effect may remain to be seen given the smaller numbers here. So just for the sake of time, I wanted to wrap this up and open it up for a couple of questions and then get onto the case. But I think what I hope to highlight here is that we have some clinically relevant pharmacogenomic influences for some commonly used antipsychotic medications, very relevant for some oral administrations. It looks like there's some definite relevance for aripiprazole long-acting injectable with some room to clarify the effect sizes for intermediate metabolizers, and some trends that look like there may be some similarities for risperidone LAI, although with less data that aren't quite as strong just due to sample size as compared to the available aripiprazole data. So with that, I wanted to conclude the didactic portion